one of my buzzwords is deliberate decision making. You want to sit down and you want to decide how you want to get where you're going. This isn't something you want to pick up and kind of do on the fly. Way too much of a financial investment to bring in an archive and then decide that you've chosen the wrong strategy. Now, another thing that I want to point out, because this is something that we've learned along the way can make the image producing departments very nervous when you start to talk about an enterprise imaging strategy. So if you look at the whole architecture of the strategy, you start with the diagnostic systems and you work down to the archives. We are downstream of the diagnostic systems. We want really no say in what goes into the diagnostic systems other than they have to be able to feed our archive and our strategy. But every department gets to choose what kind of ultrasounds they want to use, what kind of diagnostic viewer they want to use. We stay out of that business for the image producers. We want to store those images, integrate them with the EMR, and in certain cases, such as GE Provation for our women's health, we also happen to be the PACS managers, and we can help advise them, but we only do that when we're invited in. The next thing I want to talk about is our organizational structure. So Kim talked about governance, and this is what our particular governance looks like. CEM is our Clinical Enterprise Management Team. They are the group that oversees everything that goes on in the Cleveland Clinic. And they have delegated to our Imaging Council the job of overseeing our programs. And so we have the My Practice Imaging Program, which is our enterprise imaging product team or project team. I don't have in here, but I do want to talk about in our org chart that we have now evolved. So actually we have an integrated content team that deals not just with bringing medical images, but also deals with document imaging. So now we oversee integrated content into the EMR, and we're seeing a lot of convergence in the industry and a lot of parallelism in the needs of those two groups. So it only seemed the right step in the evolution to start to integrate those teams, and I don't have that reflected here. Within the My Practice Imaging team, we divide our work into three major work streams. Our clinical image library, which is dealing with ingesting images that are internally generated within the hospital into the EMR. We have our image exchange program, which deals with bringing images that are externally generated into our EMR, and also with sending internally generated images outside of the boundaries of our enterprise to other institutions that we would share patients with. And our surgical images work group, which really is a subset of the clinical image library, but we have 222 ORs, and it's such a big project that it actually demands its own space on the line and its own separate work effort. Our IT department across the enterprise works in close partnership with all of our clinical partners. Everything has a technology clinical dyad. So we have medical director. Every program that we work on has a technical team and our clinical team. And these clinical teams are our work groups, our physician groups that I have listed across the bottom. These are integral to the way we in IT operate at the Cleveland Clinic.